everybody. Welcome to today's webinar. I think we're just waiting to let a few more people in, so we'll just give it another minute and then we'll get started. Today we are looking at the key quality statement, which is safe environments, and another quality statement, say, infection prevention and control. So we're essentially merging the two quality statements together just because there is a little bit of a kind of a lap between the two, and it makes sense for us to have that conversation about how they fit nicely together. This is part of a wider webinar series that we're doing about CQC compliance with a focus on the key question of safe. So we're working our way through each of the 8 quality statements that exist and doing a focused webinar on the individual topics. So in terms of the team, meeting the team, I'll introduce myself first and then we'll go through and meet the rest of the folks. So my name is Gabi Ashton. I'm a CQC compliance and inspection specialist, and I founded an organisation called Let's Make Lemonade. So it's just putting a positive spin on CQC compliance. And I provide support in various different areas such as mock inspections, registrations, training and development, and any kind of other ad hoc queries that come up from a CQC compliance point of view. I'll hand over to Gary first. Gary next, introduce himself.
Hi everybody, so my name's Gary Hughes. I'm from my business leadership in practice. I've been in primary care for 18 years and 13 years was as a practice manager, and I support PCNs, federations to help them be the best business they can be. Over to you, Martin.
Hi guys, clinical advisor from medicine management team. Nice to meet you all.
Brilliant. And then we've also got we're joined today by Junaid, who's one of our guest speakers, who will be focusing specifically on cybersecurity. So Junaid, do you want to introduce yourself, please?
Thanks very much, Gabi. It's a real privilege to be here with everyone. My name is Junaid, as Gabi just mentioned. I'm the founder of Seigen. I'm a specialist in cybersecurity, specifically in ethical hacking and penetration testing. I'm just here to explain and make things a little bit more easier regarding how we're moving forward across data and the digital age and what we're progressing with.
Brilliant, thank you. And then last but not least, we've got Rashad here from the medicine management team. So do you want to introduce yourself and we can move on to your slide about the medicine management team and what they get up to?
Of course. Hi everybody, lovely to meet you all. My name is Rashad. I'm a pharmacist and an advanced clinical practitioner with many years experience in primary care. I also work as a director at the Meds Management Team, which is an award-winning provider of pharmacy services to GP practices and PCNs across the UK.
Brilliant, thank you. Okay, we'll skip my slide about services that I offer because I've already talked about that a little bit, and we'll move straight into the regulations. So for those of you who have attended these webinars before, we always start them with just a little bit of a foundation and sort of knowledge sharing about the background of the quality statement and how that intertwines and links closely with the relevant legislation that underpins the CQC framework. So we just want to always remind people that yes, there's an assessment framework. We probably know that there's a consultation happening at the moment to change the assessment framework. It's changed, in the last few years, but regardless of kind of what's going on from that perspective, we always encourage and want to ensure that providers are confident with the regulations and the legislation that underpins the CQC. So when we're looking at the two particular quality statements, IPC and safe environments, there are 3 key pieces of legislation that we're just going to take a quick look at. So the first one is Regulation 12, which talks about safe care and treatment. And what we've done here is we've just extracted some of the key guidance from that legislation, just to bring it home about what it is the CQC are looking for, a very specific, from a specific point of view. So we can see here that providers must make sure that the premises and any equipment used is safe and, where applicable, available in sufficient quantities. And obviously, when this legislation was initially kind of produced, equipment, I think, kind of historically, we've been thinking about equipment on from a different point of view to what we see now, which is much more about cybersecurity, online safety, the use of technology and digital innovations. But the legislation has allowed for that kind of expansion in what it covers by not being specific about the equipment that they're talking about. So that's why it's important that we think about equipment from both sides of the coin. So the physical equipment that we have on site to support diagnostics, treatment, personal care, etc., but also thinking about the online world as well. We've got here that the Regulation 12, there's a requirement to ensure that the premises used by the service and the provider are safe to use their intended purpose and are used in a safe way, and to ensure that the equipment used by the service provider for providing care or treatment is used in a safe way, is safe for use and used in a safe way. So really thinking about the intended purpose there is key, and making sure that you're not holding on to anything on site or from an electronic point of view that isn't necessary. And actually that is something that does come up quite frequently during mock inspections that I do, that historic equipment might be lying around, or you may have procured something with the maybe the goal or the aim of providing a particular service, but it hasn't come to fruition yet, or it's no longer in use, or it's been discontinued, or there's not been a risk assessment as to why that is required in the first place. And that those are things that the CQC will pick up on. So it's important to make sure that everything that you have is there for the right reason. If we move on to Regulation 15, so this is a regulation purely dedicated to premises and equipment. So this is probably the big hitter from a legislation point of view, with these two quality statements. And here the CQC are kind of, so in the first blue box, you can see that there's a reminder that providers do retain legal responsibility under these regulations. And so when they delegate responsibility through contracts or legal agreements to a third party or an independent supplier or professional or supply chains or contracts, anybody, it's really important that the registered manager and the registered providers understand that ultimately the buck stops with them from a legal and CQC compliance point of view. And I'm sure that would be something that Junaid can talk a little bit more to you about, and from a contractor and kind of third party perspective, and who we work with and how we work with them. But ultimately the registered manager does need to have assurance that that safety is being considered from that perspective. We've also got here that premises and equipment must be clean, suitable for the intended purpose, maintained and where required, appropriately located, stored securely and used properly. So, and we'll talk about that as we go through the webinar today, particularly from a walk around perspective. So looking at it from a practice manager's point of view, and we have had some feedback from another specialist, an external consultant who specialises in waste management, who was given some guidance for us about the appropriate location and storage and usage of equipment. And then last but not least, we've got Regulation 17. So this is looking at good governance. Again, for anyone who's attended the webinar before, we often come back to Regulation 17 from a well-led perspective. It's one that covers, overall management and overall responsibilities from a CQC point of view. So here we've got that the intention of this regulation is to make sure that providers have systems and processes that are able to then meet other requirements in the Health and Social Care Act. So it's basically wrapping up all the other bits of legislation that we've talked about. So to meet this regulation, providers must have effective governance systems in place. So that includes assurance and auditing systems and processes. And they must assess and monitor and drive improvement with regards to the quality and, importantly, the safety of the service provided. And then it also talks a little bit about risk management. So making sure that your systems and processes mitigate any risks relating to the health and safety and the welfare of people using the service. And it doesn't say there, actually, it says others, but it's also important to think about staff within people that you employ or contract from a health and safety point of view. So they're the three key pieces of legislation that underpin these two quality statements. And we'd always encourage people to go do a deeper dive and have a look on the CQC website for more guidance about that. But they're the kind of three highlights for you. So what we have next are some CQC extracts from recently published reports. These are all colour-coded just for reference. So any extract that we pulled that's red means that the service received an inadequate rating. Any orange requires improvement. Good is green, and outstanding will be blue. probably won't shock people to know that we haven't got any outstanding reports for this particular quality statement. It's potentially from a digital innovation perspective, there might be some reporting, outstanding reporting, but if we think about the fundamentals of equipment use and IPC, it's kind of one of those that you just have to get right rather than excelling in. So we're more likely to see goods requires improvements and inadequates under these quality statements. So we've got a few examples that we can see. So if we're able to just get all three up on the screen, sorry, I can't see the presentation, but I'll trust that all three are on the screen. So the top left, we've got here that at the time of our assessment, the practice was still undergoing building works to extend and upgrade the premises, and issues identified in our previous inspection 11 months prior, such as automatic front doors, widened corridors, etc., had not yet been addressed by the renovations. So hopefully everyone on the call will understand why that would have received an inadequate rating. 11 months is a significant amount of time to be given to rectify kind of concerns that were initially raised. And yeah, it just kind of highlights the level of detail that the CQC are going into on their revisits. So for anyone that has had enforcement action taken or they're waiting for a re-inspection from the CQC, it's just I suppose that just acts as a gentle reminder that the CQC haven't forgotten what they first came for, and they'll be looking for assurance that things have been resolved. The larger one, so the kind of middle bottom point we've got here, says that patients did not physically attend the clinic as the service was an online only one. Consultations were typically conducted via a secure video platform, and clinicians could switch to telephone calls if there were any connectivity issues. However, the health and safety risk assessments and audits had not always been completed where necessary to protect staff. So, for example, no fire risk assessment had been carried out following internal building works. And during a site visit, we found that the fire door along a signed fire exit route was locked, which would have prevented escape through the route in the event of a fire. So I think that one's interesting. We work with a lot of online healthcare providers who feel that, and we kind of won't go into the details of registration, but when you register a service, you do have to have an office or a premises where the regulated activity is carried out from, overseen and managed. So regardless of whether or not you're an online only, you still have an obligation and a duty of care to your staff who will be working from that registered office to make sure that they are protected from a health and safety perspective. So you cannot just absolve yourself of any environmental risks purely because you're an online service only. You do have to think about the premises in which the regulated activity is working from, is taking place from. So if we move on to the next slide, we've got a few more examples here from a safe environments point of view. So top left, we've got this is another inadequate rating here. So the water felt warm, but not hot, and did not appear to reach safe temperatures to prevent the growth of Legionella bacteria. When we asked to see the practice records for water temperature testing, flushing records, and the Legionella risk assessment in the practice, it was not available. They were not available or not able to provide these documents. So again, quite a fundamental gap from a safe environment perspective, and just kind of shows. And again, I think that highlights the level of detail that the CQC's inspector will go to. There's often a bit of a bugbear about inspectors. I've heard it in the past that they will go around with their finger and like look for dust, or they'll open cupboards that nothing in there and they'll be looking for things. We will turn the taps on. We will test things like the water. We'll have a look at kind of what's backing up that safe temperature. So it's just to bear that in mind that they do like to go into that level of detail. So make sure that you've got your risk assessments in place. On the next slide, we've got some good examples. It's not all bad news. We've got some good feedback. We've got here that the practice manager had good oversight of the maintenance contracts in place, and that there was a business continuity plan in place which was monitored and reviewed. So again, that highlights the importance of RM oversight, registered manager or registered provider oversight, regardless of how many different contractors you're relying on or using. And then also from a business continuity plan, I could talk all day about BCPs. I absolutely love them. I think that they can be a really, really valuable document. So I won't talk all day about it today, but I could do. But again, it just shows that the CQC are interested in looking at the usability of those and how frequently they are kind of monitored, reviewed, and and wanting to see things like tabletop exercises and mock run-throughs of areas of BCP to make sure that your staff are prepared for things that could go wrong. And then we've got here a requires improvement. So risk assessments were completed, but they did not always make sure facilities supported the safe delivery of care. So, for example, action plan recommendations from the fire safety risk assessment in December of last year and the Legionella risk assessment from the January prior had not been completed. There was no evidence of completion of the recommended action plans, and this was provided after the site visit, but the dates of the plans were not included. Overall, that's essentially just going to use the word sloppy from a risk management perspective, because there are clear actions that have been set. They've had long enough to do them, but the kind of the risk there is that even once it's been highlighted by the CQC, the quality of the risk assessments provided, subsequently was still not robust. So you do need to be making sure that your action plans and that your risk assessments are, thorough, kind of from a smart perspective, and really, really clear about timelines that you've kind of time taken to resolve those issues. If we move on to the next slide, we've just got a couple of slides now to look at infection prevention control. So similar, well, the same concept as above, looking at some reports that have been pulled in the last month and looking at the ratings given by the CQC. So in fact, if we move on to the next slide, because we've got a couple of examples there. So we've got one requires improvement and one inadequate, if that's okay. We'll have a look at those two. So we can see here that the requires improvement of the 4 staff files we reviewed, we found that 3 of the staff did not have a complete record of all the recommended immunisations for potential healthcare acquired infections, and risk assessments to mitigate potential risks had not been completed. There was a record of the required immunisations for 1 staff only. So information about records and vaccinations is a question that we get asked very frequently as part of these webinar series. So if anybody does need any clarity, there is guidance available on the CQC website, and it points you to the handbook that's available. But again, it's something that the CQC are looking for. Where you're not providing immunisations or you don't have complete records available for staff vaccinations, then you need to have a clear kind of risk assessment and a clear description and understanding as to why that's not been obtained or why you think it's not necessary as part of providing a regulated activity. And then we can see here the inadequate rating that's come up from the CQC. So the IPC clinical lead GP and staff involved in clinical procedures had not received appropriate IPC training or any IPC training, in fact. The IPC audit undertaken by the untrained clinical leader was out of date and incomplete, and it lacked reference to guidance, and improvement actions had not been followed up. So hopefully that's quite self-explanatory as to why that would have received an inadequate rating. I think the key takeaway for me there is about additional training. Often in services we see that people are given lead responsibilities or champion roles, or however you want to call it, but you do need to make sure that if you're promoting staff, regardless of whether it's a formal promotion or not, but if you're encouraging staff to take a lead in a particular area, they need to be given the time, the grace, the support to actually learn about that key topic and then be able to deliver it. Otherwise, it's a title without any meaning. And what that can do is encourage further risk, because if staff think, for example, that, oh, it's okay because the IPC lead, we hand that information over to the GP, or the GP will deal with that because that's their job, that's their responsibility, and actually they themselves aren't doing it, then there's a huge gap that could open up from a quality and compliance point of view. So making sure that you look after and you invest in any nominated leads is really, really important. Okay, so just a couple of key next couple of slides are just some key takeaways for people. So this one here, talking about safe environments and the health and safety executive, and it kind of looks at beyond outstanding. So this is essentially guidance that's available in the public domain, and it's linked, the CQC have linked created a link directly to this under the quality statement of safe environments. But it gives guidance essentially on health and safety risk assessments and how to do them. And again, I've just included this here because I do get asked a lot, and and I'm not a health and safety kind of specialist. There are plenty of people that are, but from a CQC point of view, there are fundamentals about how a risk assessment of any kind needs to be undertaken. And often people will say, how do we risk assess, or what do we risk assess, or where do we start with this? So the guidance is here for you. There are 5 key steps to think about. And I think there's just some key takeaways. So the first one I really like, identifying the hazards. So walk around the workplace, talk to staff and check accident records, for example, to find potential sources of harm. I think daily walkarounds are really, really important, and I'm sure Gary has Gary has thoughts and feedback on this from a practice manager perspective, but don't wait to be told there's an issue, I think is the key takeaway here. Daily walkarounds are essential, and they do give examples of, or they do provide you with evidence of what's going wrong, and it can help you. If you're doing daily walkarounds, it can help you quickly see other things, such as from a reporting culture, staff complacency, what staff feel may or may not be acceptable. So you can pick up quite a lot from a workplace culture perspective, as well as just the fundamentals and logistics of safe environments. I think number 2 as well, deciding who might be harmed and how. So it's giving you guidance on identifying specific groups, such as if you have got lone workers, if you've got cleaners or contractors who may face greater risks because of their role and specific job description. So really encouraging you to look at the demographics of your workforce and understand who's doing what. And again, kind of bringing it back to, you do have ultimate responsibility as the registered provider to look after your workforce and look after anybody, including contractors who support you with the overall delivery of the regulated activity. And then point 5 is interesting. So review your assessment. Again, it doesn't sound too exciting, but actually auditing your audits to make sure that they are sustainable, to make sure that improvements have been made and that they are sustained over a long period of time. That's really important. There's nothing kind of more fundamental, nothing to be gained from doing an audit once and then not revisiting it, or not looking again at what the lessons were and what changes were made and whether or not they've been sustained over a long period of time. So constantly reviewing your risk assessments is really important. So if we go to the next slide, just from an IPC and control perspective, these are the subtopics that the CQC have highlighted for everybody to be aware of when they're thinking about what IPC entails. So we've just highlighted vaccinations and waste and clinical specimen management, just as a couple to talk about. So as I've mentioned, there is a Mythbuster available on the CQC website. It's actually Mythbuster 37 for anyone that needs to have a quick Google or a quick look at that. That gives you really clear guidance about what is or is not required from an immunisation perspective in healthcare. You can make a note of that if that's something that you're worried about or concerned about. And then the other area that one of the other areas that the CQC have highlighted is looking at waste and clinical specimen management. So on that one, what we've done is we've actually reached out to an expert. Certainly not something that I'm an expert on, but it's the beauty of leaning on other consultants and other leads in the sector. So we've got here it's a colleague who I work quite closely with called Dawn. She manages Pure Waste Management Limited, and when we do kind of comms afterwards, we can tag her in that, so you can access her details if you need to, or you can just look up Pure Waste Management Limited, or Dawn, and all her information will be on there. But they're essentially, or Dawn runs an independent company, are essentially a leading waste broker. So they specialise in clinical, dental, washroom waste disposal, and support with other areas as well. So we've had a look at frequently asked questions that have come through, or that I've had from mock inspections that I've done, and what might come up. So we've put these 3 questions to Dawn, who has then provided answers for us. So if we move on to the next slide, we've got the first question, which is, what are the most common mistakes that you see in policies, SOPs, or guidance around waste management? So Dawn here has given some feedback that the biggest issues we see when visiting practices to advise on waste disposal are either they have a policy that is too strict, which means that staff cannot adhere to it, or it's too vague. So this can lead to staff guessing how to dispose of items, sometimes incorrectly, which then obviously results in risks of unintentional contamination and a breach of policy. So really, from Dawn's point of view, she's saying, if you're going to go away from this and review your policies and your procedures and SOPs, which we've spoken about a lot as part of this webinar series, just making sure that staff have clear, quick, actionable guidance that they can use or kind of refer to quickly, often whilst monitoring patients or, supporting patients and under pressure and trying to maintain professionalism. So just thinking about what systems you've got in place to support the two key roles running in tangent with each other. I think another point that she's made is that policies often assume that all staff know what to do without any defined training or role-specific instructions. So that might be, nurses versus administrative staff versus cleaners. So making sure that your policy gives clear guidance from a roles and responsibilities perspective can prove useful as well. And that links back to the IPC lead. So being specific on who does what and who should take ownership, which will ultimately reduce risk and, from a registered manager perspective, make it much easier to monitor. So making sure that people are doing kind of what's been set for them. If we move on to the next slide, please, we've got question number 2. So when it comes to sharps waste disposal, what can the person doing the practice walk around look for to ensure the process is being managed effectively? Again, this is something that I see quite often when doing walkarounds with the practice manager or the registered manager who on occasion or often is not clinical. They will say, I'll be looking at kind of sharps waste disposal, and they will then be saying, oh, that's not my responsibility, or that's for the clinical lead, or that's for the nurses to oversee. But we just want to kind of demystify that and make sure that that the registered manager or the practice manager is also empowered and equipped with some knowledge about what to look for. So Dawn has provided some top tips for us here. I won't read them all out, but you'll get access to these slides, so you've got the information available. And essentially, what Dawn has said is anyone handling sharps should know never to recap needles, how to dispose of them safely, and what to do in the event of a needle stick injury. This will reduce injury risk and help the practice run efficiently. So that's something that Dawn, also sees and kind of picks up on as part of her work as well. And then finally, we put question 3 to Dawn, which is what are out of normal scope collections that you see, and how promptly should they be actioned to avoid risk? Again, this comes up questions to me as part of walkarounds that I do, is if you have got different items or things that need disposing of or need collecting, but it's not part of the standard contract that you have, it's staff don't know what to do with it, so it just gets left or archived to gather dust. And interestingly, Dawn came back and said most of the ad hoc collections we encounter are from practices that have old machinery, chemicals or equipment, often hidden away in basements or cupboards. So these items have been in storage maybe for years and often come to light when space is required for other uses, or if the practice is about to change hands. So you can imagine from a CQC point of view that wouldn't go down very well, because the CQC are looking in opening doors and looking in cupboards and drawers, and they are having a thorough look around. So they want to make sure that it links back to the legislation that we talked about at the very start of the webinar, that everything that you do have on site has an intended purpose and is maintained from a safety perspective. Okay, it's nearly time for me to stop talking for a little bit, and you'll all be glad. So now we're going to move on to the next slide, please, which is when we're going to meet with Junaid and put the spotlight on Junaid for a little bit, for about 10 minutes, and work through the kind of key questions that we've got for him. Junaid's already introduced himself, and so what we've done is we've had a think about, again, kind of top themes or common trends that come up from a cyber security point of view. And so I'm going to put the questions to Junaid, and then I will hand over to you for your expert advice. First question is, if there is an information access delay, so aka a system has gone down or isn't accessible for a period of time, what steps need to be taken to reduce patient risk or risk to patients?
Such an important question, Gabi. I know you said 10 minutes, but I'd like to give it the weight that it deserves, because especially in a GP surgery setting, information access delay is never a technical inconvenience, is it? It's more of a clinical risk. which should everyone should have a clinical safety case report to update, and it goes back to what you were saying regarding the reviewing process of constantly reviewing. But I just wanted to think about what happens when an EMIS or System 1 goes down. The clinical team can't access any patient records. You can't safely review any medication histories, can't check any allergies before prescribing, appointment systems go dark. So I presume everyone knows the process. You're going to go to your business continuity plan, what you were talking about, and you said you really like talking about these things. But what's the first thing you need to do is you need to stay calm and don't attempt to fix anything in the attempt of a cyber attack or anything like that. I know that sounds obvious, but instinct sometimes breaks the process, and you start clicking around, restarting machines, or you start asking colleagues to try logging into other devices. These things only spread the attack even further. You literally stop. The best thing to do is just take a breath, don't touch anything. Activate or initiate your business continuity plan immediately. Start like I'm sure you have like paper-based consultations, manual prescribing processes that are already in play. That should come into effect straight away. Patient safety is paramount from a clinical hazard point of view as well as a cyber. They all go hand in hand. They overlap everything. So patient safety is paramount, and the patients can't wait for systems to come back online. I'm pretty sure everyone understands that. The next thing you should be doing with that is contacting your IT support or your managed service provider straight away. Give them as much information as you can, which systems are affected, when did it start, who clicked on something. I'm just providing a scenario for this. Did anyone receive any unusual emails, etc.? Was there any suspicious activities before this began, the attack began, or systems went down or anything like that, or there's a delay in that process? Assume the worst in this situation. If there's any possibility that it is a cyber attack and causing the delay in what you asked, rather than a routine outage, you need to treat it as a cyber attack. That means notifying NHS Digital straight away, potentially the ICO. Under GDPR guidelines, because you handle special category data, you have up to 72 hours to report a personal data breach from the moment you become aware of it. And that clock doesn't stop while you're waiting for your IT provider to call you back or sort things out for you. You have to document everything, screenshots, timestamps, who you called, what decisions were made by who. This protects you legally. It supports your data security. It supports the DSPT, which I'm sure everyone's going to be pulling their hair out next month, trying to meet that deadline. So like if this incident was ever reviewed by the NHS or the ICO, that all that evidence you've collated, all the actions that you've taken, is the difference between demonstrating that you've got good governance and in finding and dealing with the breach, rather than sitting there thinking, what do I do, who to call? Communicate with your patients honestly and promptly. A straightforward message that services are disrupted and you're working to resolve the situation goes a very long way. Patients in GP surgeries understand disruption. They would do. What they don't forgive is feeling uninformed and abandoned and left in the dark. I always like to use this analogy when I'm speaking to surgeries in a more intimate setting, is that, if one of your patients was in a waiting room waiting to be seen by a doctor and they've gone over the appointment time and so, and they collapsed in the waiting room, you wouldn't wait to confirm if it's a cardiac arrest before calling the ambulance. You'd immediately ask questions later. You'd call the ambulance and then you'd ask questions later. Same thing in a cyber attack or any such what you'd propose with the question. It's not any different. You act first, investigate second, and then you carry on with the processes. That bit of hesitation that you have can cost you quite a lot.
That's really helpful. Thank you so much. I think some key takeaways there for me. With any suspected. So you mentioned you've got 72 hours to make a notification, and that's the key word I think you said was a suspected data breach. So you don't need to confirm, you don't need to know for sure that it is one, but by any suspicion does demonstrate good governance. And then it's just to bring it back to CQC compliance, which everybody loves, to be reminded that there is actually a notification that needs to go to the CQC for any events that stop a service running safely. And again, you don't wait for the system or the interruption or the disruption to be resolved. You notify the CQC at the stage of that coming to light, and then you can keep them updated about how that's been resolved over a period of time. And then equally about, you know, being open and honest with patients. So that links very close, well, that links directly to duty of candour. So making sure that you're kind of up to date with your duty of candour processes and systems is really helpful. Thank you, Junaid. Okay, question number 2. Can you tell us about the Cybersecurity Resilience Bill? Maybe we'll keep this one short and succinct for people, and what impact this will have for GP practices. And can you provide your top 3 takeaways from this bill?
Right. So I thought about this long and hard. So the Cybersecurity Resilience Bill is the most significant piece that it's come into UK legislation that's been introduced in the past in years. It builds on existing network information system regulations, but also considerably further as we progress onto more AI solutions, because it's coming at a cost. It's leaving more businesses exposed because it's lifting all the heavy loading. It's providing a number of solutions and everyone's just jumping on it straight away. On the regulatory side of things, the gap is widening even further, meaning the scope of including a lot more things that you guys use in the day-to-day operations is all being included within this. And the healthcare sector, especially primary care providers, are in the forefront of that resilience bill. Under formal regulations, I'd say, how should I explain this now? Like if you're using Accurix or eConsult or appointment booking systems, patient communication platforms, or third-party HR or payroll systems, etc., they're all part of your responsibility now. Even though it's provided externally or it's an external software as a service, anything like that, you are responsible for that if it goes wrong, or if it causes a problem within you, if that gets breached, because even though it's provided by someone else, it's natural behavior to assume, oh, it's their fault, it's their system, they'll deal with it. But because you're using it, it falls into the remit of one of the NHS acts, which is DCB 0160. I hope everyone's familiar with that, with the 2 acts. But yeah, it falls into DCB 0160. I mean, you're more than happy. I would actually invite people to look into that, which also ties into your clinical safety case report and then your hazard logs, etc. So everything has an overlapping in creating the thing itself. So yeah, don't assume. My first takeaway on that one would be, don't assume it's the service provider's responsibility. It's yours. Second one would be, I'd say incident reporting becoming mandatory, and the timeframes are tight, as we've explained. You've touched upon the 72 hours, as I mentioned. So the bill is pushing that organizations, especially in healthcare and primary care, GP practices, the same, means having a clear, documented and rehearsed escalation process in place right now. So not in the future, you've got to have one right now. And who is your first point of contact when it comes to something going wrong? Who is the person of authority to make decisions in the first hour? What constitutes a reportable incident under the DSPT guides and GDPR, because you're handling special category data. If the answer to any of these questions are, I'm not entirely sure, that is the gap that the bill is designed to close, and regulators will be checking this. Point 3, the takeaway would be the cost of non-compliance is rising. The cost of the baseline of cyber essentials that the government is pushing, the consequence of poor cybersecurity, especially in GP practices, can feel somewhat abstract. That's changing rapidly. The bill introduces a much more robust enforcement framework with meaningful financial penalties. And I don't want to scare anyone, but the cost of that is £17.5 million, or 4% of your annual turnover. But having the security procedures in place, or getting the baseline of Cyber Essentials Plus right now is a fraction of that cost. It doesn't even equate to 0.1% of a £17.5 million fine. Up to that is. as it gets tighter, and just some inside information, as this gets tighter, they are looking to make this mandatory. It currently isn't mandatory to get a cyber essentials. However, it is favorably looked upon. I'm sure Gabi can agree with me on this, by the CQC, supporting the DSPT, any other regulatory bodies that you need to comply with and satisfy their criteria. Having a cyber essentials shows competence, demonstrates that you're taking it seriously. So in actuality, you're putting yourself ahead of the curve. The overarching message, I would say, cybersecurity is no longer a back office IT thing that your manager runs, obviously. It's a governance issue, it's a patient safety issue, and it's actually a contractual obligation. The legislation is pushing for this to be, it's going to be the reality that is catching up now in it. So it's any moment now, you're going to get a letter through the door on your business and saying, right, have you got your cyber essentials? If not, you need it now. Insurances won't insure you if you don't have this when it's coming up to renewal, etc. And we're hoping to get this by the end of this year, beginning of next year. So something to think about.
Brilliant, thank you so much. That's a huge amount to think about. Only slightly scary when you mentioned like 17.5 million. But we'll move on from that bit. I think, yeah, the key takeaway for me there was about reviewing your incident management policy and being really clear about what is a reportable incident, and maybe, you know, considering kind of categorizing different types of incidents that could take place and who then needs to be notified about what within what time frame. So you've got your regulatory bodies kind of covered and considered, as well as internal staffing processes. And then also just a reminder about it being from a CQC point of view, again, going back to the legislation, a real kind of reminder there about legal responsibility sitting with the service provider, so the registered manager or nominated individual. Okay, so last question, we've got a couple of minutes to focus on this one before we move on to Gary and Rashad and Mateen as well. We are seeing, so something I'm certainly seeing, and I know that other colleagues are, is a temptation to comply once. So essentially, you know, you do your e-learning when you join an organization, you part of your induction, and then cybersecurity and data security isn't discussed again. So why do you think online safety is aligned with fatigue compliance, and what are some of the associated risks?
You know, out of the three questions, this is probably the most important question. You know, compliance fatigue is real, and it's completely understandable. You know, GP practices as well as other primary care providers are under extraordinary pressure. You're managing clinical demand, staff shortages, contractual changes, CQC inspections. Often simultaneously, these things are happening, aren't they? And you have fewer resources than you need, especially what I'm keeping up with in the news and what's going on in the country anyway. So, you know, for example, let's say the cyber essentials thing now, you've gone and got that. It's very tempting to think, right, we've done it now, we can move on, you know, but it isn't a tick box exercise, you know. Just because you've got that, it doesn't mean the threat landscape stands still with you. The threat landscape is still evolving, it's still progressing, it's going ahead. So you can't, you have to keep on top of it. You have to keep renewing, you know, like you said about going around inspecting everything. It's sort of expecting that your digital footprint, your digital exposure, or everything that's handled within the digital framework, you want to be overlooking that, whether it's once a week, once a month, etc., to ensure everything's clear on that side of things. You know, there is a fundamental problem with this mindset of people thinking that it's just a tick box exercise. You know, new vulnerabilities in clinical software discovered consistently. You know, EMIS, System 1, these systems, your practice depends upon every single day. You know, having experienced security incidents in recent years that I've come across, you know, ransomware groups specifically target GPs. Surgeries, because they understand the pressure, they know what you have to comply by, and they know what patient records, when they become accessible, what they can do with it, because it's far beyond your name, date of birth, and address. It's your entire medical history and so much more. Other family members are related to all of that. I'm sorry, I know I'm pressed for time, but I feel I want to do justice to the question.
Do this justice, yeah.
You know, can I give you an analogy?
So, yeah, I think in terms of, yeah, well, I was going to say, I think because what we're doing now is, sorry to interrupt you, but we're going to obviously speak to Gary and Mateen and Rashad as well. And I think for Mateen, one of the questions is actually about fatigue compliance or compliance fatigue from a clinician's perspective. So it'd be good to get his perspective. But I think, yeah, I'll just trying to time manage everybody so we're not overrunning too much.
Can I just end by saying, I think everyone here demonstrates you're taking your business very seriously, and that's why you're here. So that goes to show that you take it seriously and you want to know more about it, and you're going to act upon this, and I hope you do. But don't think cybersecurity is just a project with a start date and end date. It's more of a clinical governance thing. It's just like the way you think of infection control and medicine management and all of that. Think of it like that, where it's ongoing constantly, and you'll be on the right path anyway.
Yeah, that's fantastic. Thank you. Yeah, I think that's absolutely right to not look at it with a start and end date, but it is something that needs ongoing attention. Thank you so much, Junaid. That was really insightful, and I know that you could probably do a whole webinar talking about those three questions independently. And so yeah, everyone we'll get your contact details out. So if anybody does have any questions, then they can come to you directly, or we can provide them in the responses that we do at the end of this webinar. So if we're happy to just jump straight to the speaking with the specialist question slide. So this is where we meet with Gary, Mateen and Rashad. So we've got about 10 minutes. Just to say that I can see there is a couple of questions in the chat function as well, and we have had a couple of questions submitted, one at the last webinar and one in advance of this one. So what we'll do as a team is we'll collate them all together, and independently, kind of whoever's the best person placed to answer the questions will do so, and we'll provide answers as part of these slides so that when they go out to the attendees, you'll all have access to the Q&A section at the end as well. So if you have got any questions you want to ask as part of today's webinar, please put them in the chat. We'll capture them, answer them, and get that out to you. Okay, so I might not do all these questions. I'm going to jump a little bit. But I'm going to go straight to Mateen, just because we're talking about compliance fatigue, which is something that Junaid just touched on. So having heard from Junaid, Mateen, about compliance fatigue, what are your reflections? I think particularly from a clinical, very, very busy person perspective.
So firstly, I think great points from Junaid, and I think it's really, really insightful listening from an expert point of view. So as a partner, I don't know how many partners would be aware of the protocols that Junaid was mentioning, what to do if the cyber attack happens. So I thought it was really, really insightful. So thank you for that. Regarding compliance fatigue, I think it is a real issue, and it's only going to increase given that we are bringing more technology into primary care, bringing more technology into healthcare with special AI adoption as well. We have to realize that there's a workload pressure in primary care. The staff aren't particularly happy with the workload either. There's shortages of healthcare professionals in the first place. There's operational demands. Remember, there are more appointments being made in primary care compared to pre-COVID. There's a lot of digital transformation going on. So all of these expectations are being put upon primary care and healthcare as a whole. I think the challenge is that governance, safety, cybersecurity, safeguarding, documentation, all of that, they can collectively begin to overburden an organization. And what you don't want is an organization to start picking and choosing or doing things as a tick box exercise, as a chore, essentially. And that's where, the culture needs to be right. And the culture normally can come from leadership, and leadership is normally the partnership and the practice manager from point of view. You need to feel part of the team. You need to feel that you are working alongside the team, that you're not putting people under scrutiny. You're supporting the team. The daily, what you alluded to, doing the daily walkarounds, having a look at what CQC might look at. I think that same aspect could be put into governance and compliance, really. Doing small bits at a time, but regularly is going to make the staff engage a lot better. And also education for the staff. So again, the information that Junaid is providing, how much of that would staff know about? So if you tell staff to do X, Y, and Z without actually making them aware why, then they're not going to engage. But if you educate them why this is happening, what to do, then that's where things start getting moving. And again, it shouldn't be a policy. It shouldn't be a tick box. It should be part of the culture of the whole organization. And I think the future challenges for practices will be how to maintain the high quality standards that we are expected to have in governance, while trying to simplify the processes so it doesn't provide the burden on the practice itself. Is it to do with management? Is it to do with responsibilities? And how do you manage all of these things? So I think that is the key while maintaining staff well-being.
Brilliant, thank you. Yeah, I think it's a really good point, isn't it, about the future challenges and maintaining momentum versus streamlining, and how that's going to look in reality. So it's it's good to be having these conversations, while we are now. Okay, Gary, I'm going to one of the two questions to you. I'm looking at them. So we're going to go with the risk assessment one, just because I'm always really interested in a good risk assessment. So I've put here the 5x5, so everybody knows, hopefully everybody's seen the most fundamental way that a risk assessment's done, where you look at the likelihood and severity of harm to come to a conclusion about the severity of, or how high a risk is. This is a classic format for risk assessing. What, from your experience as a practice manager and when you're supporting practice managers with risk assessments, what are some of the strengths but also pitfalls with this process, and what do you think must be considered to achieve a comprehensive risk assessment?
Yeah, okay. I thought you were going to choose the other question, but that's fine. Do you know, I've always thought that matrix is a bit limited. And I think, if everybody's honest, that's probably what we all think. And too often practices, I think it's just a bit of a tick box exercise. So I think to answer your question, strengths is simple, it's familiar, it gives everybody a shared way of, talking about risk. It's quick to do, tends to be something you can really run through quickly, it's easy to read, and it tends to sort of help discussions about risk not being too vague or emotional, because sometimes, they can be. But I think it gets more credit than it deserves, because, really a spreadsheet with coloured boxes on it is not a great risk assessment. It tends to be the end point of, what you've been thinking about, the discussions you've had. And, it's a quick, easy way to say you've thought about it, but all too often that's all you've done. You've thought and had a discussion about it. The danger is that organisations, they're very good at doing those exercises and scoring the risks, but they don't really understand, or more importantly, they don't do anything more about it. So, I think there's definitely some limitations. One of the biggest issues of all is that, many risk assessments, they're written down to satisfy governance, but they don't actually drive any action. So if the discussion ends with that spreadsheet and when you've completed it, then really the process has failed. For me, a good risk assessment, and I think this is probably the takeaway for everybody, I think the good risk assessment, you should have the right people in that discussion, the right people in the room. So, the frontline voices, whoever it is that's, relevant to it, they should be the ones in the room, not just the practice manager. It should be an honest discussion, not defensive. And there should be some real clear ownership about who's sort of taking on the management and the mitigation of that risk, because again, quite often names and initials are put to it, but people don't know about it or don't do anything with it. So real solid, robust, clear ownership, and regularly review it, because risk changes all the time. So I think being realistic, I think that 5x5 framework, it's where we are, it's what we have. But it's just worth remembering that, if you've completed the template, that alone doesn't make you safe. You've got to take ownership and move forward and do the actions.
Yeah, fantastic. I'm glad that you've somewhat binned it a little bit, because I agree. It is one of those that you see and you think, and I think you kind of hinted, and I agree that it is all that really does is reflect a moment in time. So it's a snapshot of what you can see at the moment, but it hasn't considered the who, how did we get here, who was involved, why might it have happened, how could we prevent future recurrence, and what are we going to do to monitor ongoing changes that have been made. So it's not dynamic at all, and it's something that that we hope that hopefully we can all move beyond and make it a little bit more fun.
Yeah, I think it's it's what you'd call just a very blunt instrument, but it's what we've got. So
it's what we've got. But yeah, there's more out there, so we can hopefully encourage providers to think beyond that format. Brilliant. Okay, I'm just really mindful of time, so we're just going to go to Rashad for the last question, and then Martine and Gary, like I said, we'll get your thoughts on the two other questions that we haven't had a chance to run through today, and we'll include those in the Q&As for everybody afterwards. So Rashad, when contracting to remote providers such as the medicine management team, should PMs or kind of anyone, the registered person, be concerned about safe remote environments for clinicians that they have subcontracted? So thinking about equipment being correct, accreditation, cyber essentials, etc. What are your thoughts on that one?
I'll keep my answer short and sweet. I think essentially ultimate responsibility lies with the GP practice, especially in regards to the CQC inspection, if they get one. So it's very easily overlooked. So for example, if you have excess hours and you don't want to lose the money, you only got a couple of months to claim it, it's very easy to overlook, but responsibility definitely lies with the practice. You want to be making sure you're doing your checks. If you're contracting to a third-party company like ours, you want to make sure what systems do they have in place to manage the IT. If they're going to decommission a laptop, how are they making sure that data is fully wiped and not retrievable? So it's really good to have an understanding of the provider. Do they have a training office? Are they working from home? Are they working from a garage? What business continuity planning do they have in place? For example, if the VPN goes down and they're not using a HSCN secure network, what is their plan? Do they have backup VPNs? How do they tackle it? I think all these things are very important, and it's important to really interrogate a third-party supplier before entering a contract. One question I had for you, Gabi, is have you ever known in your time of inspections, has a remote provider ever been inspected? Has their physical environment ever been inspected? It was a random thought that come to me.
Yeah, is that based on the feedback that we talked about at the beginning?
Yeah, it's a strange question.
No, not had a face-to-face inspection. I've known where they've had video calls, so the CQC inspector has done a remote call of the premises to make sure that it's safe and secure, but they've not visited face-to-face to look at it, but they are essentially doing a walk around of the location where the regulated activity is registered to take place from. Yes. Yeah.
We've been quite fortunate. We haven't had one, but I'm sure we'll do well.
Yeah, it may be coming. Okay, brilliant. All right, it's exactly 2:00, so we've done really well there, I think, with timekeeping. So there was a lot to run through, and really, really interesting topics and points from everybody. Thank you, everyone who's been able to join. And like I said, we'll gather the questions in the chat. We'll gather the additional 2 questions from Gary and Martine that we didn't run through, and the other questions that were submitted in advance, and we'll get those out to you as part of the slides. And as always, if anyone's got any questions, you know who we are, where we are, and look forward to seeing you next time. The details of which I don't know off the top of my head, but we're having a break for the summer. I think we're taking June, July, August off, so it'll be September that we're going to come back to look at safe and effective staffing, so looking at safe recruitment, and kind of support in place for your workforce from a competence and knowledge perspective. So yeah, you'll hear more information about that nearer the time, but thanks everybody and have a lovely day.